Let's have a look at the anatomy for percutaneous airways. The learning outcomes for this session are to familiarize yourself with the surface anatomy, the muscle layers, the thyroid gland and its related structures, the trachea, and then to define the two zones of safety and say a little bit about the percutaneous airways themselves. Okay, let's start with the surface anatomy. So if you run your finger down from your chin, the first hard structure you'll find running across your neck just below the chin is the hyoid bone. If you keep running your finger down, the next hard structure you come across is the thyroid cartilage. Keep going and you'll feel a little indentation below the thyroid cartilage. This is the cricothyroid membrane. And just below that we have the cricoid cartilage. As your finger falls off the cricoid cartilage, you may be able to feel a tracheal ring, and if you keep going all the way down, eventually your finger will stop at the sternal notch. Of all of these structures, the cricoid cartilage is the most important surface landmark to find your bearings when doing a percutaneous airway. If we cut away the skin, we have the subcutaneous tissue, and just underneath that we have the muscles. The first layer is the platysma. This is a very superficial muscle which lies on both sides of the neck. In the midline it is joined by the superficial cervical fascia. If we strip away the platysma, underneath we have the strap muscles of the neck. These are the thyrohyoid muscles, the sternothyroid muscles, and the sternohyoid muscles. And flanking these on both sides, we have the omohyoid muscles. No muscles are actually divided for a percutaneous airway. Only the superficial cervical fascia is divided in the midline. The muscles are then gently separated in the midline and pushed off to either side. If we take away the muscles, the next important structure we come across is the thyroid gland. This consists of two lobes which lie on either side of the trachea and extend upwards towards the thyroid cartilage. They are joined in the middle by the isthmus, which lies across the trachea, usually at about the third to fourth tracheal ring, although it can extend upwards towards the thyroid cartilage and even across the cricothyroid membrane. Let's have a look at the blood supply of the thyroid gland, and we'll start with the venous blood supply. The thyroid gland is drained by three vessels on either side: the superior thyroid vein, the middle thyroid vein, and the inferior thyroid vein. The superior and middle thyroid veins drain into the internal jugular vein, and the inferior thyroid vein drains into the brachiocephalic or innominate vein. It's important to note that although the inferior thyroid veins usually drain into the brachiocephalic veins, this is often not the case, and their course can be quite variable. Sometimes it can be a single vessel, or even a network of vessels lying across the anterior surface of the trachea. Now let's have a look at the arterial blood supply. The thyroid gland is supplied by two pairs of arteries: the superior thyroid artery and the inferior thyroid artery. And very rarely there can be an IMA artery which supplies the inferior border of the isthmus. The superior thyroid artery is the first branch of the external carotid artery, and the external carotid artery arises from the common carotid artery. The inferior thyroid artery is a branch of the thyrocervical trunk, and this in turn comes from the subclavian artery. The IMA artery usually arises from the brachiocephalic or innominate artery. If we strip away the thyroid gland, underneath that we have the trachea. This is covered anteriorly by pretracheal fascia. It is normally 10 to 16 centimeters long in adults and has 15 to 20 tracheal rings. The cricoid cartilage is in fact the first ring, and there can be up to 6 rings in the neck that you might be able to feel all the way down to the sternal notch. There are no nerves that lie on the anterior surface of the trachea. The paired laryngeal nerves can be found on either side. Let's look at the different types of percutaneous airways. There are two. There's the cricothyroidotomy and a percutaneous tracheostomy. The cricothyroidotomy is the only emergency surgical airway that should be performed. It is performed in the zone of safety. This is, in fact, the area where you find the cricothyroid membrane. It is relatively superficial, and there are no muscles, vessels, nerves, or part of the thyroid that overlie this area. Percutaneous tracheostomy is performed in the zone of relative safety. This is the space between the second and third tracheal ring, or the space between the third and fourth tracheal ring. There are no significant nerves or blood vessels in this area. Any vessel that you do come across can be safely tied off if necessary. It would usually be a branch of the anterior jugular vein. Always remember to make a transverse skin incision to reduce scarring. And if, when you dissect, you come across a large thyroid gland extending above the second ring space and up towards the cricoid, it's best to stop and get the surgeons to come and perform a surgical tracheostomy. The third area I'd like to talk about I've called the no-go zone, and this is the area that extends from the fourth tracheal cartilage down to the sternal notch. Here you will find thyroid isthmus as well as a plethora of vessels. It is a very vascular area and is not suitable for any form of percutaneous airway. In summary then, a knowledge of the relevant anatomy is essential to safely insert a percutaneous airway. Always remember the zone of safety for your emergency surgical airway, the zone of relative safety for a percutaneous tracheostomy, and the no-go zone, which you need to keep well out of. And just to have a look again at our learning outcomes, we've looked at the surface anatomy, the muscle layers, the thyroid and related structures, the trachea, the zones of safety, and briefly at the different types of percutaneous airways. Thank you.